Hello, this is Emily Bauer, Master's of Science Options student at the University of Southern Maine. This is my case presentation for Nursing 601 Advanced Pharmacotherapeutics. So this is the case we'll be looking at. We have a 70-year-old woman with COPD. She has been admitted to the hospital and here for a follow-up visit, and she is admitted every 6 months. Here's a list of her medications. She's on Advair, Spiriva, lisinopril, metoprolol, and aspirin. So my first step is to evaluate this patient, especially looking at her readmission rate and whether that's due to her COPD exacerbations. I would check her post-bronchodilator FEV1 to see if she needs a stronger COPD medication. I would also look into her medication interactions, which we will discuss in a little bit. I would ask her about her substance use, especially tobacco use, as smoking is correlated with COPD. And if she's using tobacco, I would strongly recommend quitting, offering her some resources, the quit line, seeing if she's interested in any sort of medication or nicotine replacement therapy to help her quit. And finally, I would inquire about her medical and social history to see if there are any underlying issues that could be contributing to her readmissions. So based on her readmissions, her age, and COPD diagnosis, I would run through the ABCD assessment with her. I would also have her complete a CAT score, CAT assessment. And so based on the finding that she's had, at least 2 hospitalizations this year from moderate exacerbations, this is going to place her in group D. So based off of her group D classification, let's look at her COPD meds. So the first one we have is Advair 550, which is an inhaled corticosteroid LABA combo of fluticasone and salmeterol. It is indicated for maintenance of airflow obstruction and reducing exacerbations in COPD. It is not indicated for acute bronchospasm. So based on the GOLD guidelines, which we can, I guess we can't go back. I'm recommending that she's elevated to a LABA-LAMA combo, such as Spialto Respimat or tiotrium olodaterol. And additionally, Advair 550 has not been shown to reduce exacerbations over the 200/50 dosing. So that would be another reason why not to continue with this one. So again, it's not the best option to treat as it's contraindicated as the primary treatment of COPD that requires intensive measures. So the alternative could be the Spialto. The cost is much higher for the Advair 550. It's about $267. The 250 Advair apparatus is $167, and Spialto is about $189. So when she was taking this Advair, it was twice daily maintenance, 12 hours apart. It can, if someone has a hypersensitivity to milk, it contains lactose, so that could cause an adverse reaction. Also has an increased risk of pneumonia, and most importantly, interacts with beta blockers. As we'll talk about later, she was on a beta blocker, may block bronchodilatory effects, and produce severe bronchospasm. So we want to monitor lung sounds, including coarse crackles, her ability to breathe, and mucus production. Teaching points would be a rinse mouth after inhalation to reduce risk of oropharyngeal candidiasis. If shortness of breath occurs between doses, an inhaled SABA should be used, and she should not use with cardiovascular disorders, dysrhythmia, or hypertension. So next, let's talk about Spiriva. It's indicated for long-term once daily maintenance Treatment of bronchospasm associated with COPD, again, not indicated for acute bronchospasm. So it is indicated to reduce exacerbations, but she may have better results if we switch her to the Spilto. Spiriva is about $104. Would be 2 inhalations once a day the last 24 hours. Some reactions could be urticaria, angioedema, and rash. And again, we want to monitor lung sounds, work of breathing, and mucus. Spiriva teaching would include only taking it once every 24 hours, not for use in acute bronchospasm, and stop use if there are any adverse reactions. So now let's take a look at her cardiac medications. We don't have all the information about her heart history, but let's look at the meds. So we have lisinopril 10 milligrams once a day, which is an ACE inhibitor. So we need more information about her hypertension history, comorbidities, especially diabetes mellitus, and her race, whether she is white or non-black or black. If she falls within the JNC guidelines of, let's say, she's over 65, let's say she hasn't met her blood pressure goal, she's white, she doesn't have diabetes mellitus, she falls into these guidelines, then lisinopril 10 milligrams is a good place to start. If it's not effective, you could add hydrochlorothiazide. Lisinopril is affordable and accessible. It can have some adverse reactions, including headache, dizziness, and a dry cough. We want to monitor how low her blood pressure is getting and the work of the heart. And we want to teach about these side effects, the headache, the dry cough, the hypotension, and to discontinue if she's experiencing any angioedema. Next, we will discuss the metoprolol extended release 50 milligrams. This is a beta blocker, which is indicated for hypertension to reduce blood pressure and risk of fatal and non-fatal cardiac events. Again, we need more information about her cardiovascular event history, but it is contraindicated with beta agonists, can produce bronchospasm in COPD patients. So we're going to say across the board that we would not recommend she continue with this medication. There are alternatives, as we've already discussed, an ACE inhibitor, a diuretic, or an ARB. And then finally, we have aspirin, 81 milligrams once a day. It's over the counter, indicated for relief of pain, fever, inflammation. It can reduce the risk of having another MI or stroke, but hasn't been shown to reduce the first one. It is a good medication, but we need more information about why she's taking it. It can diminish the effect of an ACE inhibitor, so we may look at an alternative. It's affordable and accessible. The dosing could be anywhere between 81 to 325 milligrams once a day, according to the history of her cardiovascular events. There are some adverse reactions to be aware of, including GI upset, bleeding, and dizziness. Monitoring is going to include a reduction of pain, inflammation, and long-term looking at any repeat cardiovascular events. Teaching points would include not to take with Advil or Aleve. It reduces the effectiveness of aspirin. Do not take aspirin if hypertension is uncontrolled. And just be cautious with cuts or bruises for the risk of excess bleeding. So just to recap my recommendations, seeing as she's moved into Group D for the COPD guidelines, she needs an elevation to a LABA-LAMA combo such as Spilto. We want to monitor the dosages of her prescribed medications, adherence, any barriers such as cost or transportation that could be impeding on her from taking her medications? Is she using her inhalers correctly, and any side effects that she may be having? These are the sources that I used, and thank you very much.